those of you here who are patients, and those of you here who are family, or who are friends of patients, or working on a cure, or working to improve lives, will know what I mean when I say that when you're coping with long-term chronic illness, memories like that remain etched on your brain forever. About 2 years after diagnosis, I underwent my first surgery, and a year later my second. And it was on returning to school after that second surgery that the second moment remains etched on my brain. You see, I went to public school. In England, that's a term for posh school. I hated it, but my parents were proud that they had a son that had a brain that could get in. But anyway, I went to public school, I arrived at assembly, and I sat down in my seat, and I noticed there was a seat spare next to me. So after assembly, I marched up to the headmaster, and I was like, "Excuse me, sir, why was there a seat next to me empty?" Anyway, he said, "Michael," actually, no, it was posh school. He said, "Sears," and he looked me straight in the eye, very unemotional, and he said, "Well, you've got Crohn's disease. I don't want another pupil catching it." Over the next few years, both my social lives and my work lives were interrupted through various surgeries. After 20 operations, I ended up at the point of intestinal failure. And I remember being sent by my surgeon for a gastrographin test. Gastrographin test is where you're supposed to swallow this liquid that basically they tell you tastes like aniseed. Actually, it tastes shit. But I had a nasogastric tube at the time, you know, one of those tubes that goes in your nose and down. And the nurse spent ages persuading me to swallow this liquid. And she did, but within about a minute, I managed to recycle that liquid. Not only did I recycle it, the nasogastric tube that was coming out my nose also came out my mouth. Hey, I could floss. It was wonderful. Intestinal failure led me to a life of intravenous feeding. And those of you who are patients and those of you who are clinicians will understand what I mean when I talk about a life with permanent lines, such as Hickman lines and PICC lines. And then I was told that my only hope was an intestinal transplant. And so, on the 7th of October, 2011, I became only the 11th person in the UK to undergo a rare small bowel transplant at a hospital called the Churchill Hospital in Oxford. My transplant journey was the toughest thing I'd undergone in my life. Nothing and no one can prepare you for that journey. Nothing and no one can prepare you for that moment when you have to say kiss goodbye to your loved one and not know if you will ever see them again. Actually, what I'm saying, some of it isn't quite true, because the only people who really can help you are fellow patients. And that is why I firmly believe that peer-to-peer interaction, patient-to-patient interaction, is an absolutely vital component of healthcare. Communication over my 30-year journey has changed dramatically. The way we receive and consume information is changing by the day, and there are many of you in the audience here today who are at the forefront of that change. However, let me please just put technology to one side for 1 minute, because for me, the single most important change in my 30-year journey is this. The balance of power has shifted towards the patient, and it is continuing to shift. How decisions are made, and crucially, who is making them, has changed. And it's not just about the how and the who. The options available for consideration are massive. Every single day, we are given a new tool, a new app, a new gadget to wear, a new piece of technology, a new this or a new that. But there's also one other new something. How I make my decisions and why I make my decisions has changed forever. These 11 tools are my dashboard. They help me make my decisions in healthcare. The final image on here is very important to me because I wouldn't be standing here today without the help of two very, very special people. My transplant surgeon, Anil Vaidya, and the person I'm about to introduce you to. It's extremely humbling for me to be able to stand here today and introduce you to the lady who literally not only helped save my life, but changed my life. So without further ado, I'd like to introduce you to Marion O'Connor.
Thank you, Michael. I first met Michael when he was referred for an intestinal transplant at the Oxford Transplant Centre. The Oxford Transplant Centre is one of the largest transplant centres in Europe, transplanting kidney, pancreas, and now intestinal and recently abdominal wall transplants. My experience prior to this was with intestinal, obviously chronic gastrointestinal diseases and intestinal failure. As I said, chronic complex illnesses, inflammatory bowel disease, intestinal failure, short bowel syndrome, and then now intestinal transplant. The significance of this to our talk today is that these patients suffer from a chronic illness where it's often that they have several regular visits to hospital. As a result of this, they have very little control on their lives, and attending or communicating with hospital personnel it becomes a major and a significant part of their communication. And therefore I feel it's important that we get this right. For these patients, they often cannot eat or drink. They have often failed medical treatments where they're waiting for the next drug to be come on the market to see if this will help them. They often have obviously live with the risk of a central line sepsis or developing other conditions as a result. They often cannot support support employment, so therefore they're unable to support themselves and their families. So obviously it takes a lot of the control away, so attending hospitals is a part of the experience for them is in coping with their condition will be the experience they feel in hospital. And I think I'd probably go as far as to say it's a determinant in whether they cope with their condition or not.
Okay. You're going to hear an awful lot about technologies today, about how healthcare's changed, about the use of digital this or that. What we want to spend the last 10 minutes of our opening keynote is really talking to you about what is happening on the ground in the UK, what is actually happening in outpatient clinics and on the wards at the moment. Because we're privileged. We talk to an audience here today. You all know what's going on. You're at the forefront of everything. You touch all the latest things. But like a lot of patients here today, I sit on the wards, I'm in the outpatient clinics, and Marion deals with patients like me every single day. We want to give you some practical tips, not just tips, but practical stories as to what is happening out on the wards. So, do you want to take a seat?
Thank you.
And I thought you were going to sit this side, so I moved my notes here. That's fair enough. Okay, in the build-up to transplant, I turned to the busiest doctor in the world, Google, to try and find out what was going on. But actually, Google had very little about an intestinal transplant, and my wife and my kids were getting bombarded with what's going to happen here, what's going to happen there. You're going to a hospital, and you're number 11, and hey, the first 5 didn't make it, so how do we know what's going to happen? So I started writing a blog. It was no more exciting than that. It was just as a way of telling people what was going on. Anyway, about 18 months later, somehow this bloke from a little town in sort of northwest England has 76,000 followers reading this damn blog. But anyway, what I'm really interested in is I'm lying in ICU and you suddenly find out about a patient that comes in with a blog. How did you feel?
I think firstly I must say that although we're obviously working within transplant, there's a requirement to be kind of fairly highly specialist in what you do from all disciplines, and we certainly weren't. We probably were very much amateurs at social media, and this is where what we're going to talk about today is our experience over the last 5 years of intestinal transplant. How did I feel? Well, I didn't really have an idea what a blog was. I have younger siblings, so I think I probably had a memory of hearing them talking about it and felt, well, that's very much for them. Until we were looking after Michael after his transplant, which is transplant obviously is major surgery, and there's lots of very complex discussions on the ICU afterwards, trying to sort out all those initial problems. And then we would be at his bedside again. Michael wouldn't be really with us; he was out of it most of the time. And then a colleague of mine or within the team would say, "Oh, I see you're doing this for Michael, and you're doing that." And I would think they weren't even in the room, and they weren't even sometimes in the hospital. And on one occasion, I think somebody was away on holidays, and I began to become a bit curious about how they knew this. So that's when I decided to have a look. And I think when I did, I was asked the question at the time, and the answer is it didn't bother me, because I think being a professional, and it's about being professional. We would have done the same job for Michael if he wasn't blogging. It was part of what we did. And I think what really impressed me, if I was to remember back, was the fact that at the point when we were in the room with Michael or on ICU, it wasn't Michael that was writing, and it certainly wasn't the junior doctor was busy writing, but I seriously doubted it was to add to Michael's blog. And so when I read the blog, I realized it was Justine, Michael's wife, who'd been filling in the details during that time. And I think what impressed us all, and continues to impress us all, is the accuracy of Michael's reporting, and the fact that he actually, within his blog, respects us and respects our role, so that he will check with us if there's something that we're working on and we don't want, obviously at this point, or if there's something we don't want him to put in, he will always do that. Hence, his blog has been integrated very much into our intestinal transplant program.
And for me and you guys, communication has really moved on in terms of the last couple of years as to how we talk to each other. We communicate pretty much daily by text. The other day my surgeon was like, "You're coming to San Francisco, don't forget your sun cream, and or you better take a hat with you."
You didn't.
And I didn't, I forgot it, so he's going to kill me.
You're going to have to tell him.
But also, I get texted my phosphate levels, my blood results, and we keep communication going that way. He's even started tweeting me. I mean, it was very interesting when he decided, instead of direct messaging me, to tell the world what my phosphate levels were. But the truth being, actually, no one else cared about my phosphate levels, except about 10 other transplant doctors from around the world who were going, "Have you checked your magnesium and have you checked your zinc?" But using these technologies are really great in terms of how we communicate. And really, it kind of started with an email. And, before coming to Oxford, I'd been a patient a long time, but actually I'd never even had the email address of one single doctor. Until suddenly I turned up and he said, "Here, you can email me." But you've used email for quite a long time. How are the benefits for you? I mean, if you strip it right back and we put all technologies to one side, even basic email is an advance for some people.
Absolutely. I mean, I was fortunate enough prior to getting involved in intestinal transplant to work with the Oxford intestinal failure team. And obviously we have, again, it's very complex. We have patients out in the community, not within our county, but obviously within the rest of the parts of the country. So they have central venous catheters in place. So obviously we need to know what's going on really on a weekly basis. I mean, it would be physically and virtually impossible for us to call those within our busy daily lives, so working. So what we would do is they would email us. So every week, I mean, obviously, one of the points I'd like to make about all of this is that it doesn't replace patients calling us if they've got problems. So this is the time where we're trying to keep up to date with what's happening with the patients. So they would email us, or they would call us or email us, and then each member on the team, that email would be forwarded to the appropriate member of the team related to the problem, that they would, and all of the other team members would be aware. So every Wednesday we have a multidisciplinary team meeting, and the advantages of the emails was that everybody in the room, even the consultant who was away maybe for some of that week, was fully informed of what had actually been happening with that patient for that week.
Do you feel then that using even basic technologies is improving health outcomes?
Oh, absolutely. I think we have a very good relationship with the patients, and I think we inform them by email. We keep them involved in what their blood results are. I mean, for me, I thought this was just normal and natural thing to do.
Wasn't
but
for
obviously,
me.
I've learned since, and it's not. But I think it's because I think we feel that if patients are informed and involved in their care, and even if they have any anxieties, you can't wait until they come to their clinic in 3 or 6 months' time and see a doctor for 15 minutes, probably a different doctor that they've seen the last time, who's really interested in telling them, basically, oh, this is what I want you to do. And I think emailing and sorting the problems out before. I think also the other advantage is they sometimes find it easier to communicate with, say, the nurse or the dietitian or the pharmacist or someone that they related to sometime, or if they have concerns. So I think this allows the communication to happen before the clinic visit. So when they come to the clinic visit, then you have an answer to the problem, which I think is what you find.
Yeah, and also what I find is a real practical benefit is we're sharing our experiences on a daily basis. We share articles with each other, we share videos, we share ideas. So, I'll give an example. I was lying in hospital with this ridiculous headache over my right eye, and doctor after doctor was coming in going, I have no idea what's going on, but you've got a headache and you don't suffer from them. And he said, just go and see if somebody else will know. And I went out to one of the groups I'm involved in on LinkedIn. And I just said, look, I've got this pain in my eye. Does anybody ever had anything like that? And a really lovely lady came back. She said, I bet you've got shingles. So I go back to the surgeon and I go, Anil, I've got shingles in the right eye. And he's like, flipping heck, I've trained for 20 years and you've diagnosed it in 2 minutes on LinkedIn. But it's a way. It's just because the team are so receptive to go, okay, this is two-way. This is not just about me, the doctor, telling you to do this. Let's share information. The other instance when you wanted to try this transdermal cream, magnesium cream, and he's like, I don't know if it works. Go and ask one of your patients. They'll tell you if it works and what the side effects are. But that takes a very special medical team to embrace and want to be able to do that. That goes up, for me, over and above what potentially is the norm. But this is what's happening every single day. And, I'm privileged to reap those benefits. So I've got a question for you. With all this technology, who leads the way then, the doctor or the patient?
Definitely in our experience, the patient. And all of our patients, I think we've learned from all of our patients, and we've experienced how we have this little network of patients now who all communicate with each other via either email or Facebook or Twitter or whatever. So yeah.
And, classic example of some real outcomes. I think my daughter decided she wanted a picture in the paper, so we got an article out there. But what that article did was, okay, it highlighted transplant, but a guy in Scotland made contact with me who had never before, his surgeon had never ever heard of a bowel transplant. We got him down to Oxford. 4 months later, he had a successful transplant. And that had a further knock-on effect, didn't it?
It did. I mean, this particular patient's quality of life was so poor, and it was never going to get any better. And so for him, this is huge, made a huge difference. And within Scotland, there was another patient who had read this article in the paper. He was a young guy, again with a similar poor quality of life, who then approached his consultants and his kind of funding authority, who then said, well, actually, we need to wait and see what happens with this guy. And because this was a successful transplant and successful for the patient as well in improving his quality of life, they then agreed for the other patient to have a transplant, and he's now also undergone a successful transplant.
Yeah, so, patients can have a direct impact on outcomes of other patients where doctors don't even know that these facilities are available. And we've been able to move it on at Oxford in a big way. We've just started tweet chats. When the surgeon actually remembers what hashtag he's supposed to be writing, it's a really interesting experience. Because on a Saturday morning, what happens is he sits down and starts this great conversation in depth about going through transplant, and then he's texting me on the other phone, how do I reply to this? But it's a great example of the way forward, and we now have Skype clinics, don't we, which is a huge impact for patients.
Yes, I mean, we're just in the early stages of developing Skype clinics, which is very important within transplant, because for intestinal transplant, and I can only talk about intestinal transplant because that's my only experience within transplant, but it's very, very important that any symptoms you have, that we get on top of those from a very early stage. And so it's important for us to have communication with patients regularly, not just when they've got problems, but also when they're okay. Because sometimes patients think, well, I'm okay, I feel great, but actually there's probably a maybe slightly increase in their stoma output, or they feel a little bit off. And to us, that signals, okay, hang on, we need to see you. Some of these patients, I said, are outside the region, so it's not as simple as saying, oh, well, come down and in the next couple of hours and we'll see you. This could take all day for them to travel down. So this allows us, I think, to feel safe, and that the patients are safe, and that we're aware of what's going on.
But all of this leads to, and you come up with your great rule book in terms of how you engage online. And there's a lot of discussion and a lot of debate was, how does the doctor and the patient engage with each other online? And I know you kind of come up with sort of 5 rules that you abide by and that Oxford abide by.
Yeah, I think that definitely with all of the patients, I have a fantastic group of patients where I think are tremendous and very brave people, and I admire them a lot to have gone through what they've gone through.
You should.
So I think we are ourselves with them, which I think is very important. But probably the most important thing is about being professional. And I think that really for me, I don't see why I would say anything to Michael, whether it be in an email or in whatever format, that I wouldn't say to him in front, because it's about being a professional. I think also what's necessary is you need that kind of respect from the other side as well, that the patient respects that you are bound by professionalism and professional boundaries as well yourself. And it's no different to having a clinic consultation where you would do the same as in the format of a Skype clinic.
And we've, in a sense, taken the whole development thing further, because we're here talking about the future of health in a way, but I'm a great believer that patients can be innovators as well. And a classic example was I'm lying in bed having had my transplant, and part of that is you have an ostomy. Those of you that don't know what that is, when part of the bowel is pulled out to the stomach and everything's collected into a bag. And I'm lying there thinking, this is great. I've got a bowel on the outside of my stomach that I've got to look at, then I've got to change it, and then it's filling up at ridiculous times. And then I've got Marion over here prodding me going, can you fill an Excel spreadsheet and tell me what the output is and what time the output is and what's the volume? And I need to know this.
What colour?
And the colour. How do you... the colour and the consistency. And I'm thinking, I've just come through transplant. And the truth is, how do you do all of that as a patient? But, there are a lot of people that come up with a lot of innovations that are far cleverer than I am and a lot of others. But I think it has to start with the patient. And what we were able to develop was this basic sensor that clips on the outside of any ostomy bag. It Bluetooths to a free mobile app that you download, you enter in all your details, Soma, and then all it does is you set an alarm, and as the bag is filling and the bag curves, it alarms on your mobile like any other ring and lets you know what's going on. But the beautiful thing for me is I don't have to fill in any more spreadsheets, because it automates the volume, the time, and it allows me to send it A, up to a cloud, but B, to Marion, so she gets a beautiful thing. And then she comes back to me and says, can we add pictures to the app for colour? But, we've worked together an awful lot, haven't we, to develop tools like this. And I think, our feeling is that new technology is great, but if it starts with the patient and starts with the patient and clinician, you're going to get a better result.
Absolutely.
Is that a fair?
I would say absolutely. And as regards Michael's invention. I think we're all very excited about it. More so for the reason that obviously I've been working with patients for stomas for probably over 10 years, and yet I can help them to advise them to what to eat to reduce the output, how much loperamide to take, things like that. I cannot, there's nothing I can do about the feeling when they come in and it's so desperate and they're so upset because, they've been out with their friend, they're they're teenagers sometimes, they've been out with a friend and their bag has leaked, and the effect this has had on them, and the fact that they can't speak to other people about it. And so for me, definitely, I'm very excited about this. And already, although we haven't had one, we've got a kind of a line of people who are in that kind of situation, who I'm very hopeful will be helped by something like this.
Yeah, and patients can have fun too. We can come up with some very strange looking bags and prints and things. So, hey, why not? But I just want to wrap up with a couple of things, because, I come at this from a patient, so I'm biased. So all these patients that are sitting in the room are, for me, are just absolute heroes. And I think, we're kind of top of the pile, even though you're the genius and we just sit there and get things done. But, when the NHS comes out and talks about believing in social media, and the Mayo Clinic come out and talk about it, you kind of realize it's a big game. And we've been able to implement these on the ground, so to speak. This is sort of down and dirty, practical situations that are occurring that I think together we've been able to use technology. But one question I did want to ask you about social media, so what happens when a patient rants? How do you cope when that patient goes off at the deep end?
Well, I can probably answer this because it's actually happened in the last couple of weeks. And
not that I set that one up. But
yeah, no, but I can tell you actually the answer for me would be it doesn't bother me, because as a professional, I think I would still treat that patient in the same way as if they hadn't, because that's my duty to the patient, and I think that.
But it must be hard when they are ranting, and boy, we know this one ranted.
Yeah, it is. It's difficult because, well, I think it's difficult, but I think you have to, if you believe that what you're doing is the right thing for the patient, and if they want to get on board with that and then help themselves, fine. If they then decide that that's not what they want, but they won't approach you to discuss it, then there's not a lot you can actually do. And we do encourage, and I'd say this is probably the first time in 10 years, I think, it's the first time that it's happened, or the without social media. And I just think that there's nothing much we can do about it, really.
Hey, listen, when we started on this journey, I remember the chairman of the Transplant Foundation saying to me, you want us to have a Facebook page? I'm like, yeah. He goes like, but don't people want silence? I'm like, no, really, Facebook would be really, really good. And then a patient ranted, and he was like, see, that's why we don't want it. And I was like, no, that's why you do want it, because if you'd answered or responded, that problem would have gone away. But you didn't respond.
Yeah. And I think that's a very good point. This is what we try to do via our emails, and obviously as well, is to try and prevent that getting to the point where people are full of anxiety and nobody's listening. And I think that's the problem. If people feel there's nobody listening, especially in these kind of chronic illnesses, then it makes it harder to actually work with these patients. Their outcomes are going to be affected. Compliances to your treatment is going to be affected. And I think what we've seen is that if you can get the patient on board, then all of those things are improved, which makes your life much easier, and obviously their lives much easier. You don't get all these, people imagine, you're going to get lots of calls, and you don't, because actually the patient is empowered to manage, their situation or their condition better, and they know that they've got access to someone at whatever time to answer those questions.
So, the short term is technology for us on the ground is improving communication. Yeah. One of the points I want to touch, does it improve compliance as far as you're concerned?
Well, I believe it does. I mean, going back to transplant, obviously the idea of a transplant, any organ transplant, is to help the patient, but also to, I suppose, to reduce the burden on the patient, but also on the health service, because, and so therefore you need the outcomes to be good obviously to justify this. One of the most important aspects of transplant is compliance. So if patients do not comply to their immunosuppressive drugs, then obviously the organ rejects. And we find that if you like this regular communication, effective communication by whatever means, some people don't want to email, don't want to go on to Twitter or anything, so we give them all the choice, and then we phone them if that's the option. But we definitely find that our patients are very compliant, and this is probably seen in our outcomes in the last few years.
At the end of the day, we've talked about increased patient engagement, we've talked about solving anxieties through use of technologies, and I hope that we've been able to give you a brief insight into life in the trenches at Oxford. And thank you very much, and enjoy the rest of your conference.